And palliative care is really the holistic care of people and their families. So we're looking at the physical aspects, the psychological, the social and the spiritual aspects. And there's been a great deal of collaboration between palliative care services and neurology. And I think also neurology services do provide palliative care and need to be aware of the issues that patients and families may bring. There's increasing evidence within palliative care in general, whether in hospital, at home, or in the hospice, that palliative care may improve quality of life, symptoms, and is very much appreciated by patients and families. So they actually talk very positively about that. And there is increasing evidence within neurology. There are several studies now that have looked at that and have shown symptoms improve, quality of life improves, and families and patients feel very supportive. And so that's what I'm hoping to encourage neurologists to think of how they provide palliative care themselves within their services, and also how they can collaborate with perhaps specialist palliative care services locally and in the community and in the hospital so that they can provide that care. I mean, one study I was involved with, which was Simon Veronese in Turin, did a randomized trial on palliative care. And he had two groups, one group who they were involved with immediately and the other group after 16 weeks. And they found that the symptoms of the people who had the specialist palliative care team involvement had fewer their symptoms were easier, particularly pain, bowel symptoms, sleep, and also their quality of life improved. Whereas the control group who had their symptoms didn't improve and their quality of life actually decreased. Now, it's always very difficult within palliative care and with very disabled patients to measure quality of life. Many of the quality of life measures actually become very low very, very quickly with neurological patients. And so we use what's called the QoL quality of life scale, which actually asks patients, what is the most important part to make your quality of life? And they come up with several things that are important to them, and then they rate them so that they can see that, and then we can come up with a score. And that can vary over time. So, for instance, initially someone may say, I like to go to the football, I like playing with my grandchildren and going out to the restaurant with my wife. They're my three top things. And they rate and they come up with a quality of life. A few months later, someone may not be able to do those things, but they may say, I can't go to the football, but I enjoy watching it on the TV. I can't play on the floor with my grandchildren, but I really enjoy them coming along and I read them a story. I can't go out to a restaurant with my wife, but we still have a good meal. She cooks me a lovely meal and we can sit and drink and have a meal together. And so their quality of life may be as good, if not better, in their assessment, even though they're very disabled. So that was an important way of looking at quality of life. The other study was in Czechia, which again looked at a group of patients with MS, ALS, and Parkinson's disease. And it was a multidisciplinary clinic approach. And then again, they saw that there were improvements in symptoms, in emotional issues, in social issues, in the spiritual area. Interestingly, not in the religious area, in the non-religious. So it was the existential feelings that someone may have and quality of life. And that was, again, over a period of 3 months. And I think the most important thing out of both of those studies was that it was a multidisciplinary approach. There were the doctors and the nurses, but it was including speech and language, physio, occupational therapy, social worker, psychology, and the very different, looking at all aspects of patient care. And I think that there is now the evidence that we can take forward.